Namaskar, welcome to today's session of Critical Lines. And today it is my pleasure and honor to invite and have with us Dr. ABDUL Ansari, one of the leading intensive care physicians in our country based in Mumbai. So, Dr. Ansari is Director of Critical Care Services at Nanavati Max Hospital, Mumbai, and he has a vast experience of over two and a half decades. He serves as a faculty and guide for various critical care training fellowship programs, and his specialty has been mechanical ventilation and sepsis management. He has been an integral member of several task force committees and helped to draft various policies in the past. He has been honored by the Honorable Governor of Maharashtra, Mr. Bhagat Singh Koshari, for his dedication and his great work during the COVID epidemic. And he's also been awarded the Max Outstanding Award for his services in critical care in Max Hospital over the last several years. So indeed, a remarkable achievement, sir, and we are indeed honored to have you with us today.
Thank you, Tapesh. Thank you. And I must take this opportunity to thank you for creating this wonderful platform, Tapesh. And I know how much hard work you have done over the last couple of years to really establish a platform which is clearly only for education. And thank you for inviting me here. And it is always a pleasure to see with the kind of passion with which you pursue teaching in critical care. Thank you, Tapesh, once again.
Yeah. Thank you very much, sir, for all your support. This has been possible only with stalwarts and supporters like you, who has been associated with us right from the beginning, and the immense support I've got from you and from all the faculty members within our faculty group, which is informal, but soon we'll be formalizing it into an organization. And so many people from outside our faculty, also the group that we have, who have supported us. So my thanks to everybody, and also to the audience who has reciprocated our initiative with equal enthusiasm. So thank everybody, and I think it's a win-win situation. We try to do good, and we are getting good. So I think that's a wonderful thing. We believe in free education, and I think we are going to go a long way with this and help everybody. Okay, sir. So we start kicking off with the first point, and focus will be on sepsis today, guys. More questions on sepsis, and that is sir's forte also. So, as our viewers might have read and heard, there's a lot of buzz around use of beta blockers in sepsis. And beta blockers used in sepsis would probably be counterintuitive because they are known to cause hypotension. So, at the outset, one may wonder, why should we be using beta blockers? So, my first question to sir is, sir, what is the rationale behind the use of beta blockers in septic shock?
So, Tapesh, this is actually still regarded as a very controversial area, especially in septic shock. In fact, any kind of shock, thinking about a beta blocker sounds very, illogical, where you are thinking about vasopressors to get the mean arterial pressure up, and thinking to, kind of reduce the kind of myocardial kind of oxygen consumption so that you can reduce the cardiac output or control the heartbeat. Sounds like slowing the horse when the horse is running fast to kind of provide cardiac output to all the organs. But in the same thing, there is also a very beautiful counter argument hidden, that if the horse gets too tired and goes into a kind of state where the myocardial lactate utilization or production is so high that the myocardium cannot sustain it, then it leads to ultimately the decline, where the cardiac output actually starts falling down. The myocardium itself is actually suffering oxygen debt, and despite a good anaerobic threshold, most of these people will go down. So is there a fine tune or a kind of mid ground where we can kind of reduce the myocardial oxygen consumption and make it more efficient a device, while the source control, volume, and other targeted therapies are taking care? Just to kind of come up, that beta blockers have been very clearly identified as a force in cardiogenic shock, of cardiac origin, obviously, because a shock of cardiogenic origin, because it does help the suffering myocardium. it helps the kind of myocardium which is compromised with blood flow to reduce. The infarct size comes down. The stunned myocardium gets better. But the fact that these benefits can be done after optimal hemodynamic stabilization has been tried in septic shock and various forms of other areas where gradual controlled reduction of heart rate has been beneficial in overall outcome, and especially with ultra short acting agents, it has been shown in the past also with esmolol and now with landiolol that it can definitely benefit in selected patients. I would very importantly say that we need to really wait for more wider data to kind of make it more easily usable. But a controlled usage of beta blocker in these scenarios is definitely welcome after the initial storm has kind of settled or kind of abated.
Right, sir. So, sir, you mentioned metoprolol and landiolol. So, would you like to touch about these beta blockers, sir, especially landiolol, because I think it's a new beta blocker.
So, landiolol actually is not available in our country yet, and in a lot of our countries. Japanese people have worked a lot on this. They have actually shown the first important study, which I could, study was about effective reduction of heart rate with a quick, short-acting landiolol before coronary angiography. So, whenever those CT coronary angiographies were being done, they tried using placebo as well as other drugs and tried reducing the heart rate by giving a small short dose of landiolol just before the procedure, and they found very effective reduction in the heart rate, so that the studies were very well performed. So that was the first indication that it is very effective in a short term, even in an outpatient setting, very beneficial, no signs of bronchospasm. And then these studies were extended into a few more trials where they tried using it into the ICU settings in various forms of undifferentiated shock as well as cardiogenic shock, and showed that it can reduce the heart rate without significantly changing the kind of blood pressure and not having any adverse effect on the mortality. So that was landiolol, and there was one very nice study with esmolol in the past, which was very, very beneficial, where pure septic shock esmolol infusions were given to control the heart rate in the range of 80 to 90, and they found that that was actually beneficial in improving the cardiac output measures, although it was not powered enough to talk about mortality benefits. But in that study, it did show a 30 to 40% mortality reduction, which was too good to be true. And it was again questioned for the kind of biases which were inherent in the study, a single center study.
Right,
And
sir.
also, metoprolol has been studied to show that non-cardioselective actions of beta blockers are actually beneficial in these kind of shock settings where they don't kind of cause any adverse effects, as contrary to our imagination that it may cause bronchospasm, probably raise peak pressures, airway pressures, but they have never been shown in these studies.
Right, sir. Thank you, sir. Sir, so finally, what is the practical takeaway? Should we kind of use it cautiously? Is it being used in the world, or was it? What is it, sir? Now.
So in fact, one of the drugs that we have been using of interest, the funny channel ivabradine, has been again kind of considered as innocuous looking, chronotropy reduction drug. But again, that was compared on head with a couple of other studies. They found that it was as effective in reducing the heart rate, but it was not beneficial, especially in the patient with atrial fibrillation. So they definitely didn't want to produce it further. In fact, it may be harmful in that setting. But ivabradine probably has been the closest to any other beta blocker for rate control. And I would suggest that only after the initial ebb and the flow of septic shock or cardiogenic shock has settled, probably adding it to control the heart rate, tone it down so that there is better myocardial optimization without causing significant hypotension. The take home can be that we can safely bring the beta blockers in the arena after initial septic shock and the organ dysfunction has started to stabilize.
Right, sir. Thank you, sir. So then moving on further to septic shock again. So now let us say the septic shock is in a resolution state and we want to taper the vasopressors. So a lot of our junior colleagues want to know, is there a protocol for tapering? How should we taper, etc.? So can you throw some light on this, sir?
So before tapering, I would say that the tapering actually starts for right indication and the right timing. And that is something which is the most contentious area in our sepsis, where fluids and vasopressors are so nicely intertwined that there is very clear study now documenting that very early vasoactive agent usage, what is called as the very early vasopressor usage versus delayed vasopressor. In fact, if you notice, the latest surviving sepsis guideline addendum says that within 1 hour, vasopressin, norepinephrine should be initiated, even though it can be started from the peripheral lines. And that is something which is very important, which points towards a very important fact that early usage of vasoactive agents, especially norepinephrine in general, is highly encouraged. And they have shown a very important link with diastolic pressure. The starting diastolic pressure, if it is less than 52, then waiting for fluid to get the tone up is usually delaying the restoration of effective MAP. And there is another concept called as the diastolic shock index. That means heart rate divided by DBP can, if it is more than 2.2, a late starting of vasoactive agents actually causes more harm. But we must remember that very early group where right at the start of shock, starting vasopressin without giving fluid can actually not allow the fluid deficit to be corrected. And that is one of the most common reason for persistent requirement of vasoactive agents after initial successful taper. So I hope I'm putting my point across that those people where overzealous addition of vasoactive agents are done without goal-directed fluid administration, which is not necessarily 30 ml per kg. It is 5 to 10 ml per kg of fluid given initially as a fluid bolus. And obviously those who are fluid responders and who are fluid tolerant, both. So fluid responders and fluid tolerant, given a reasonable amount of fluid, ongoing gentle fluid resuscitation going on, institution of vasoactive agents, especially norepinephrine early on within the first 1 hour, and getting your MAP targets, slowing down on the fluids, waiting for 24 hours. If you are not needing more than 0.25 micrograms per kg of norepinephrine to maintain your MAP, then most of the time the tapering is usually easy. If you are needing more than 0.25, there are two strategies, which we will talk about. And as we discussed, thinking about a relative adrenal insufficiency or adding of another different mechanism of vasoactive agent like vasopressin. And if you have done this and sustained for 24 hours with lower, that is 0.01 or what we call as on an average 5 microgram per minute, that is you are using a moderate to low dose of single agent, probably tapering succeeds. If you have still ongoing MAP requirement of some kind of additional support, look at fluid deficit and correct it with a colloid if possible. I'm sorry for putting in so many things, but simple things. Start early with concomitant fluid resuscitation. If it can be directed with some kind of ultrasound guidance or dynamic measure, great. You have got some fluid build up so that the MAP can be sustained. Get early on a vasoactive agent and see that your vasoactive requirement is not climbing up. If it is climbing up so much that you are crossing the norepinephrine on a higher dose or needing a second dose rescue drug, it could be anything depending upon cardiac output, whether dopamine, epinephrine, preferably vasopressin. In that case, tapering should be very gradual and slow. And in that case, it is recommended, expert guidance, no hard and fast guideline that hydrocortisone should be added there because they have an unmasking of relative adrenal insufficiency or SIRCI, what we will probably very commonly spoken about. No clear guidelines, but that's probably one of the major reasons why they falter. Early on, early stabilization, quick taper, they falter. Either fluid or relative adrenal insufficiency is unmasked. Over to you. Sorry.
So just to put that in, slightly further direction. So it's often, if you are on a single drug, like you said, norepinephrine is not much of a problem. But very often they are on Norlin and vasopressin. So is there any choice here? And, here if you can just kind of specify.
Septic shock, there is enough trial. Soap trial, Clover, Sensor, Vanish. You can keep on talking about them. 1 hour would be less for only enumerating the trials. And all of them repeatedly are coming to the conclusion, you don't need to reinvent the wheel. The wheel is very clearly established and robust. It is circular. That you have to use norepinephrine by default. It is very beneficial, very safe, less arrhythmogenic, always works. If for some reason, because of inherent bradycardia, poor cardiac output, or certain special features, or it is not tolerated, in that case, probably that's the only condition where epinephrine and very rarely dopamine can be default additions. Otherwise, vasopressin most of the time should be able to give you a MAP. But if you're not able to get an effective rise in the DAP or the MAP, in that situation, you may have to increase the norepinephrine dose first, looking at the fluid optimization, the volume, infusion, pump, and the tanks. So you look at all the pipes, the contractility, and the tanks that you are not fluid overloading, give adequate fluid, and increase the dose of norepinephrine to 0.25 to zero point 0.5 microgram per kg. If you have reached this state, that means, and it is not sustained for 4 hours, MAP more than 65, you need to look for alternative causes. Is there also associated hypovolemia? Is there something else? Is there a distributive or an obstructive shock? And then add preferably vasopressin. That's standard in a dose of 0.01 unit per minute, can go up to 0.04. If you are reaching up to 0.04 unit per minute of vaso as an add-on, this is red flag. There's something which you need to reassess, find out the source. Are we missing out something? Your drugs are okay, renal dysfunction, liver dysfunction, and probably don't be in a hurry to taper it off at this point.
Right, sir. So thank you, sir. And moving on to the next question. Uh, now, you often come across a situation that the shock is resolved and you are on just minimal dose of noradrenaline. But the moment you shut off noradrenaline, the blood pressure again becomes anti-systolic, and you're not really able to taper off. So the patient is good now, but not able to stop the noradrenaline infusion. So what are the possible reasons for this now? The blood pressure is not coming to normal without minimal support also of noradrenaline. What possibilities can you think of, and what should you do?
So I think I touched a little bit on that in my elaborate answer before,
Yes.
but the first and the most important thing is, are we treating the right phenotype of shock? Is it septic shock, cardiogenic shock, mixture of that, distributive shock, obstructive shock? If it is pure septic shock, everything is pointing towards that. Your numbers are very well, and you feel that everything is looking okay. In that case, there is something which is probably not allowing the myocardium to be into the right frame to function. Look at the contractility, look at all the other performers, and look at the cardiac output per se. Is it underperforming cardiac output, or probably the body is not able to match? So look at the VTIs and other cardiac indices to really understand whether the pump efficiency is okay. And then very important word which is called organ input pressure, which is what is always forgotten. In septic shock, which is different than all the shocks, is that there is different critical closing pressures of every vascular bed. So your mesenteric, kind of vascular bed, your peripheral vascular bed, your, pulmonary parenchymal vascular bed, they all will have different critical opening points, and that will be dependent upon the organ pressures. Most of the time, that organ pressure. So look at your lactates here. If your microcirculation is not getting better, whatever you may be doing, there is perpetuation of shock into the cellular level, and this will not allow the stabilization. So that's where you need to think about adjuvant therapies, which is different. Look at the organ support. Is there adequacy of organ support or no? And then obviously come the hormonal imbalance. Think about whether there is a quick relative adrenal insufficiency. Is the patient immunocompromised? Do I need to really kind of give some kind of more additional? And very commonly people are forgetting that there could be that the patient may need metabolic resuscitation. This is one of those outlier groups where metabolic resuscitation actually can help. Unfortunately, blanket septic shock, we have killed the HAD therapy. I completely understand. I'm not a very big proponent of that, but I think it had a place. So these kind of situations where hydrocortisone replenishment along with other nutrients can be beneficial. And sepsis guidelines talk about 200 milligrams of hydrocortisone, either in infusion or breaking doses, should be administered. And I would say that if your single vasoactive agent norepinephrine dose is already climbed up 4 times, starting from 0.01, you have already gone up to 0.25 microgram per kg. You need to institute hydrocortisone at that point of time and take it off if shock resolution can easily happen in 48 hours. It is beneficial and difficult to prove in any randomized controlled trial. It's such a heterogeneous population, we can't do that. So that's one. And number two, the septic phenotype. These are the two important things which I will think of. And sepsis-induced cortisol insufficiency, as we call Turkey, critical illness-induced cortisol insufficiency is a real term, and it is increasingly being recognized. Unfortunately, there is no test which can differentiate that. People tried, using those, corticotropin test, a synacthin test, but they are too difficult to be interpreted. So I think add it if you are finding it difficult to get your targets.
Right, sir. Sir, and any comments on patient becoming hypoalbuminic and hypovolemic because fluid moves out and loss of vascular tone, especially in the elderly and diabetics and all with or autonomic neuropathies. I think is there a role for these kind of patients also contributing to this?
I personally feel that's the concept of delayed resuscitation. Lot of people have arbitrated. I personally, let me put it to you, I never look at the albumin concentration because it falls down. There is always so much of fluid shift between the compartments that if you measure the albumin level of a person whose albumin was 4.5 on day zero, and next day it will come down by 1 gram, 3.5, and there is no reason to substitute that. But if your shock resolution is not happening and you are continuously giving crystalloids, I think that's a bad policy to keep chasing with some 40 ml, 60 ml of IV fluid continuously, causing fluid creep, and you are just adding more of solvent to the patient who is already having a increased volume of distribution, and it's not gonna open up your closing microcirculatory beds. Probably there, because of the ubiquitous properties of human albumin, I personally feel rather than giving that big volume, a steady small amount of albumin infusion can be beneficial in a small subset, especially if there is associated liver and renal dysfunction. If they are not there, probably you may do more harm, because now instead of crystalloid, the colloid will seep into the interstitium and cause more volume. So please take my this word with a lot of caution that this can be a strategy to just bide some time, and you must couple it with some kind of active de-resuscitation. And that's the Rose concept. Resuscitate, optimize, stabilize, evacuate. So if you're giving any fluid continuously beyond the initial resuscitative phase, you need to think about actively de-resuscitating that fluid.
Right. Thank you, sir. So then moving on to the concept of capillary refill time. Hernandez et al. Has done this Andromeda study. It's been a couple of years now, and they showed very nicely that it's better than lactate. Though it's a very complicated study, and capillary refill time, is very useful in resource-limited countries. It doesn't cost anything, and studies have shown that it's better than lactate, better than CO2 gap, which is very complicated, and better than even the saturation gap. So also other markers of perfusion. Studies are there. So I think, sir, a lot of our viewers are from, the resource-limited ICUs. Of course, there are other people also, but and I think this is a very useful technique. So maybe, sir, you can just kind of talk about capillary refill time, the physiology, etc., and whatever you want to tell about capillary refill time.
So if you ask me, capillary refill time, we used to start our kind of training when we were in 2002 or 2003. That was supposed to be the most important marker. But as a resident at that point of time, I realized when the capillary refill time was obviously prolonged, the patient was certainly going to die. So which is a clear found fact that capillary refill time, if it is more than 5 seconds, it's a bad prognosis. Your hands are pale, they're blanching on simple pressure, they're not filling up. And that's what I meant by saying that there is a critical closing pressure. By the time the muscle, skin, and all the peripheral areas, the capillaries are closed, the blood is not going there. And this is what your vasoactive agents are further doing the damage of closing all the peripheral so-called redundant capillary beds, where you don't want the blood to flow because you want the blood to flow to the brain and the heart and a few vital organs in the core. Now, that's a defense mechanism. And so checking and CRT is a very commonsensical thing. And I think it is very advantageous that it has come back from good institutions where they have looked at that, and that can be a good take home for all those LMIC, lower middle income countries, and smaller rural places, and even good places as clinicians can actually teach their students that look at the map, but look at the capillary fill time. Just look at the capillary fill time on the patella or on the kind of lower limb or the peripheral nail beds. And if you even look closely, you know that there is blanching. But blanching and mottling will follow very quickly. So only relying on capillary fill time as your measure of sepsis is probably taking the cart too ahead. I would say that's a very important thing, a very early sign to distinguish. And believe me, it is highly specific. Highly specific. If your CRT is crossing 3 seconds, I would be very worried whether my map is good or whatever it is. So all the students who are listening, I would say that you cannot ignore CRT. Please don't get me wrong. It is very important. The physiology is very clear. Those capillary beds, which you can easily see, they are just not filling up because they're closing off. And so are closing off the kidneys and the liver and the other organs and the mesentery, and causing the lactate buildup because tissue dysoxia is progressing. But what very beautiful thing endometrial shock and other studies did, that it is comparable to good cardiac output measures, which shows the limitation of our sophisticated tools. So commonsensically, look at the map, look at a microcirculation in between a CFT comes very well. And if you can serially look at that, it is very essential. And I would suggest that that could be there is a very nice trial by there is a very nice article which I was reading just today itself by Nicholas Page about effect on capillary refill time of volume expansion and increase of norepinephrine dose in septic shock. I would recommend, and I think we can I can provide you this article. You can put it on the link. Probably those people who are listening, they should read, because you will find that in conclusion, in septic shock patient with prolonged CRT, it very rarely improves with treatment. That was they were saying. And more than 23% improvement is significant, which is very difficult to quantify. So don't rely on that, but do test it. Keep testing it in an emergency ED setting or a smaller setup, or those people who are going to institute advanced monitoring. Please don't ignore CRT. It's very important. Over to you, Tapesh.
Thank you, sir. Thank you. Very nice words and a lot of experience there. And from my side, just a takeaway, please use capillary refill time. It's a very nice test, like sir has said. It doesn't cost anything. And if you get used to it, you'll get good results. You have to start doing it. So use capillary refill time as a marker of perfusion and read about it also. There are a lot of things to capillary refill time, like sir has enumerated some of them. Now, sir, just a quick question before we wind up about Amiodarone. Something we use frequently and something which has a lot of side effects also. So one has to be very careful with Amiadarone, and is used in precarious situations. So just what about its modification, the dose modification in renal disease and in hepatic disease?
So, Tapesh, as far as we have been, in fact, there was a very nice adage that the arrhythmias are of only two types, that Vaughan William classification is not required, Cordron's responsive, non-Cordron responsive. That was one of the old, jokes that we used to have when we were studying, that all the arrhythmias will either respond to Cordron or not respond. But coming back, it's such a ubiquitous drug that it has been probably overused. And the biggest problem is that Cordron can kind of cause serious problems. Apart from corneal microdeposits and thyroid issues, it can actually be badly accumulated in liver dysfunctions, especially cirrhotics and liver dysfunction. It can be a major problem. Dosing guidelines are very poor and rare. But renal dysfunction, in my opinion, there should be no major concern. You can continue with the appropriate dosing. Liver dysfunction, first 24 hours, you can use it to control the rhythm. And at least not the rhythm, but the rate, get it down. You can use it in full dose, or at least 600 milligram in 24 hours can safely be given for a reasonable adult. And as far as the infusion strategy is concerned, because a lot of people like to load it up to a few grams in the first 72 hours up to 7 days, that strategy has to be gone with cautiousness. Get a hepatologist on board, get on those lookup tables for the dose adjustment of Cordron, or look at or more safer alternatives, especially diltiazem, verapamil, if you can. But I feel Cordron is a very important drug which cannot be missed out, especially in life-threatening arrhythmias, because it is highly effective, is reasonably well tolerated, except when the cumulative dose crosses, 3 grams is standard, but if it even crosses 1 gram in liver dysfunction or renal dysfunction, you have to be really vigilant.
Yeah. Okay, sir, I think thank you very much, Dr. Ansari, sir. Wonderful. And it was, I think, highly educative for me and I think all our audience. So I thank Dr. Ansari, sir, for being on our channel, and look forward to having him again on our channel and his continued support. Thank you, sir. Thank you very much. And I thank the audience for their patient hearing and for their participation. Thank you, dear viewers. Thank you, sir. Thank everybody.
Have a nice day. Thank you. Thank you, Tapesh.